Hello, my name is Scott Steenberg. I'm an emergency radiologist at Indiana University School of Medicine in Indianapolis, and today I'd like to talk to you about imaging of traumatic aortic injuries. I have two financial disclosures listed here, but they are unrelated to the content of this talk. There are three learning objectives of this talk. The first is to describe the various imaging appearances of traumatic aortic injuries on various imaging modalities. Second is to describe the pitfalls and common anatomic variants that may mimic aortic injuries. And third, to list the existing definitions of minimal aortic injuries. First, we'll start with a discussion on the clinical background and mechanisms of injury for patients with aortic injuries. We'll then discuss the various imaging modalities available to us. We'll then talk about major aortic injuries, such as the injuries seen here. We'll then briefly discuss minimal aortic injuries, followed by imaging pitfalls and anatomic variants, and wrap up with patient management and imaging follow-up. Traumatic aortic injuries are the second most common cause of traumatic death in road traffic accidents, second behind traumatic brain injury. A vast majority of these patients, over 80%, die usually at the scene, but at least before reaching a trauma center. However, patients who do survive to get to a trauma center, a majority of those patients will ultimately survive their injuries. The literature says about 40% of patients have other severe coexisting injuries. In my experience, that percentage is actually higher than that. And a vast majority of patients with aortic injuries are seen in the setting of high-speed motor vehicle collision, by definition, which is over 30 miles per hour. The short-term outcomes of untreated traumatic aortic injuries is quite dismal. The historical literature from the 1950s shows that approximately half of patients will die within 24 hours, which is the time frame during which an aortic injury is most likely to rupture. However, newer literature from the 1990s shows an even higher mortality rate within 24 hours, with most of these patients dying. It's thought that because of improved in-field care, rapid transport of patients from the scene to a trauma center via helicopter or interstate system has gotten these severely injured patients who in the past may have died from the injuries are getting to the trauma center and then dying. Traumatic aortic injury morphology spans a wide spectrum, ranging from minimal intimal injury all the way to transection with active bleeding. However, most aortic injuries are secondary to a transverse tear in the aortic wall, resulting in a pseudoaneurysm formation. The image on the right, you can see contrast collecting outside of the aortic lumen and what appears to be a dissection flap, but this is not a dissection. This is contrast opacifying a flap of the aortic wall in the axial plane. If we look at this image in the sagittal plane of another patient and imagine yourself scrolling from top to bottom, you encounter this level where you have contrast surrounding an intimal flap in a patient with a large pseudoaneurysm. Shearing injury is felt to be the primary mechanism of injury for patients with aortic injuries. This happens primarily at the relative fixed points of the aorta, primarily at the ligamentum arteriosum. Other potential theories include hydrostatic forces, where increased intraluminal pressure overcomes the tensile strength of the aortic wall, as well as osseous pinch due to crushing injury of the aorta between the sternum and the spine. These last two theories may not be as significant as previously thought, and shearing injury is felt to be the primary cause of aortic rupture. The aorta can be injured anywhere along its entire course, from the aortic root to the aortic bifurcation. However, a vast majority of patients with aortic injuries occur at the aortic isthmus or the proximal descending thoracic aorta at the level of the ligamentum arteriosum. There are a number of imaging modalities at our disposal for evaluating patients with suspected aortic injuries. The primary modalities are chest radiography, computed tomography, and catheter angiography. MRI, though it can evaluate aortic injuries, is not typically used in the acute setting. Intravascular ultrasound can acquire high-resolution images of the aortic wall. However, it requires a special probe and expertise to perform this. Transesophageal echo also requires specialized expertise, but can be performed in the operative suite if the patient is too unstable to undergo computed tomography. The workhorse for trauma imaging, especially of the aorta, is CT. A chest X-ray is routinely obtained in the trauma bay for the initial imaging evaluation of the trauma patient, primarily to detect life-threatening injuries requiring immediate intervention. However, some information about the mediastinum may be obtained. You cannot use a chest X-ray to reliably diagnose and exclude an aortic injury. Thus, you cannot clear the mediastinum with a chest X-ray. And any mediastinal abnormality on chest X-ray warrants further evaluation, usually with CT. Understandably, patients with major aortic injuries can have substantial mediastinal hemorrhage, which is what distorts the mediastinal anatomy as seen on a chest X-ray. The findings on chest X-ray for thoracic aortic injuries include many things, but one thing you should not rely on is mediastinal widening. The old idea that mediastinal widening greater than 8 centimeters is sensitive for aortic injuries is not true. You can have normal, non-widened mediastinums with an aortic injury, and you can have wide mediastinums without an aortic injury. Other imaging features include abnormal aortic arch and aortic contours, left apical pleural capping secondary to hemothorax near the apex, rightward tracheal shift, inferior deviation of the left mainstem bronchus, and rightward deviation of an NG tube. Here's a classic chest X-ray of a patient with a traumatic aortic injury. We have abnormal mediastinal contours with an ill-defined aortic arch. We have inferior displacement of the left mainstem bronchus. We have rightward deviation of the trachea and NG tube, and left apical pleural capping due to hemothorax. Here's another patient with mediastinal hemorrhage secondary to a traumatic aortic injury. We have indistinct, ill-defined, abnormal aortic and mediastinal contours, rightward deviation of the trachea, and inferior displacement of the left mainstem bronchus. There is a left apical pleural cap, though it is less evident compared to the prior image. Aortography historically was the gold reference standard for the diagnosis and exclusion of aortic injuries due to its high performance metrics. In the era before advanced CT technology, any abnormal mediastinum on a chest X-ray would warrant further evaluation with catheter angiography. This was low yield, it was time intensive, it was expensive, and it was invasive, and over 80% of the angiograms were negative. Current day, catheter angiography is delegated primarily to a problem-solving role and for treatment. Take this patient, for instance. This is a patient with a transthoracic gunshot wound. On the left image, you can see a large amount of mediastinal hemorrhage with contrast foci not clearly within vascular space. The image on the right demonstrates a large bullet fragment with extensive beam hardening artifact obscuring the vasculature. It's difficult to exclude or diagnose an aortic injury based on these images, but it was felt to be high risk for an underlying aortic injury. At aortography, you can easily see that there is rapid opacification of the pulmonary arteries due to an aortico-pulmonary arterial fistula. The patient was treated with an aortic endovascular stent graft with post-stent aortography image on the left and post-stent pulmonary angiography on the right. Early research of aortic injuries with CT began in the early 1990s, and even then, using older technology with conventional and single-slice CT, accuracy routinely exceeded 90%. This was slow to gain acceptance within the surgical field due to the severe nature of this injury. So at that time, any abnormal CT would undergo confirmation with catheter angiography, and understandably, this would increase the rate of true positive angiograms. Contrast-enhanced CT of the chest has effectively replaced catheter angiography as the primary screening and diagnostic tool for traumatic aortic injuries. Current CT technology for detecting and excluding aortic injuries has high performance metrics. If CT is unequivocally positive or unequivocally negative for aortic injury, then no further evaluation is necessary, regardless of what the mediastinum looked like on chest X-ray. But if a CT is equivocal for an aortic injury, then further evaluation is necessary, keeping in mind that catheter angiography will likely still be low yield, so further evaluation with intravascular ultrasound or transesophageal echocardiography or cardiac-gated CT may be warranted. The direct CT signs of a major aortic injury manifest primarily as a pseudoaneurysm or a contained rupture contained by the adventitia. Active bleeding from the aorta can be seen on CT, however, it is very rare and is often later fatal. Abnormal aortic contours can occur, as well as aortic pseudocoarctation, which is manifested by acute intramural hematoma and narrowing of the lumen. Again, with pseudoaneurysms, the intima and media are almost always injured, contained by the adventitia. However, the adventitia can be injured in up to 40% of patients, which is often rapidly fatal. However, there is some potential for temporary tamponade from the surrounding soft tissues. In this image, we see an aortic pseudoaneurysm involving the proximal descending thoracic aorta. Again, this looks like a dissection, but it is not. We're simply seeing contrast collecting outside of the aortic lumen. Here's another patient with a major aortic injury. There's a focal defect along the anterior surface of the proximal descending thoracic aorta, resulting in a contained rupture or pseudoaneurysm. And here's another image of another patient with a transected proximal descending thoracic aorta with pseudoaneurysm surrounding the injured site and intimal flaps noted proximally. Here's another image from a patient with a major aortic injury. There's an injury of the proximal descending thoracic aorta with contained rupture or pseudoaneurysm and a large amount of mediastinal hemorrhage. Again, this looks like a dissection flap, but it's not. This is contrast extending beyond the aortic wall. Here's another patient with an injury to the proximal descending thoracic aorta with pseudoaneurysm formation. Here's another patient with a major aortic injury. The chest X-ray shows abnormal mediastinal and aortic contours. Coronal CT image through the chest demonstrates a rupture of the right lateral wall of the thoracic aorta with a pseudoaneurysm formation. The patient also has a left diaphragmatic rupture with herniation of the stomach through the diaphragmatic defect. Here's a patient with blunt thoracic trauma demonstrating a pseudoaneurysm of the proximal descending thoracic aorta. The image on the right shows diffusion of contrast into the mediastinal soft tissues. Sagittal oblique image demonstrates active bleeding from the aortic rupture. Most of these patients who are imaged with CT will succumb to this injury. The indirect CT signs of an aortic injury are less important now in the advent of high-resolution multi-detector CT. Mediastinal hemorrhage and perivascular hemorrhage are indirect signs. However, as you can see in the patient on the right, there is mediastinal hemorrhage with a clear fat plane between the hemorrhage and the aorta, which was uninjured. If you do see indirect signs of an aortic injury on CT, you could do a number of things, including follow-up chest CTA without or with cardiac gating. You could do catheter angiography, however, this is likely going to be low yield. You could also do intravascular ultrasound. Let's shift gears and talk about minimal aortic injuries. These smaller aortic injuries were encountered as early as 2001, and at that time were defined as small intimal flaps with minimal to no periaortic hemorrhage. The original study found that approximately 10% of aortic injuries are these minimal types, as you can see here in an image from the original paper showing a small intimal injury with intraluminal thrombus. Notice that there is no periaortic hemorrhage. And at that time, they correctly predicted that these minimal aortic injuries were, quote, a lesion associated with advancing diagnostic techniques, unquote. So these injuries were small enough that using older CT technology just weren't identified. Minimal aortic injuries are also called minor aortic injuries, and there is no universally accepted definition in the literature. However, those definitions that do exist include intimal injury with intraluminal thrombus, an intimal flap less than 1 centimeter in length, a pseudoaneurysm less than 1 centimeter in size, contour abnormality adding less than 10% to the diameter of the aorta, and by definition, these often have little or no mediastinal hemorrhage. So major aortic injuries are far more likely to be encountered than minimal aortic injuries. The initial research indicated that approximately 10% of aortic injuries are the minimal type. However, more recent literature suggests that these minimal aortic injuries constitute approximately a quarter to a third of all aortic injuries, so far more common than initially thought. Our own experience at Indiana University finds that minimal aortic injuries constitute 36% of all aortic injuries. Minimal aortic injuries are most frequently encountered in the descending thoracic aorta. However, compared to major aortic injuries, they are more spread out and distributed along the course of the aorta. Here's a list of some of the most recent literature on minimal aortic injuries, which I'll summarize on the next slide. Minimal aortic injuries constitute approximately a quarter to a third of all aortic injuries. The thoracic aorta is more commonly injured than the abdominal aorta, and often this occurs in the absence of peri-aortic hemorrhage. Mortality related to minimal aortic injuries is very low, though some embolic events may occur in approximately 10% of patients. Non-operative management has overall favorable outcomes. There's no universally accepted follow-up imaging algorithm for patients with minimal aortic injuries. However, a vast majority of these patients will see stability or resolution on follow-up. Let's look at some images on patients with minimal aortic injuries. On the left, we see a small intimal injury with small intraluminal thrombus. Notice that there is no peri-aortic hemorrhage. Patient in the middle also has an intimal injury with an intraluminal thrombus that is slightly larger. Again, no peri-aortic hemorrhage. Patient on the right, a different patient has an intimal injury with intraluminal thrombus, and again, no peri-aortic hemorrhage. Here are 3 images from 3 different levels of the aorta on the same patient, showing multifocal intimal injuries with intraluminal thrombi. Here's a sagittal image through the thoracic aorta showing all these intimal injuries with intraluminal thrombi. Here are 4 images from 4 different levels of the thoracic aorta on the same patient showing all of the imaging manifestations of minimal aortic injuries. The 2 images on the left show intimal flap less than 1 centimeter in length. The top right image shows a small pseudoaneurysm. There is aortic root motion artifact, and the aortic root was not injured. And the bottom right image shows an intimal injury with small intraluminal thrombus. Now let's look at the natural evolution of patients with minimal aortic injuries. Here's an admission CT image on a 42-year-old female following a motor vehicle collision showing an intimal injury with intraluminal thrombus, which is unchanged at 24-hour follow-up. However, after 1 week, this injury has resolved. This is the typical course for patients with minimal aortic injuries. Let's look at some other images on a 25-year-old male following a motor vehicle collision. At admission, there is an intimal injury with intraluminal thrombus, which partially resolves on 3-day follow-up. After 8 days, the intraluminal thrombus has resolved. However, there is subtle contour deformity of the aorta at that level. 15-day follow-up shows interval development of a small pseudoaneurysm at the site of previous injury with small amount of peri-aortic hemorrhage. This is not the typical course for patients with minimal aortic injuries, though it can occur. There is no universally accepted follow-up imaging algorithm for patients with minimal aortic injuries. In the literature, there's variable intervals between follow-up exams, and typically imaging follow-up ends once the aorta returns to normal appearance. But what we don't know is what to do with stable injuries that persist over a long period of time, and we're not sure which injury types need follow-up and to what extent. One proposal published by Dr. Martin Gunn from University of Washington suggests that if the patient does have a minimal aortic injury, that it be followed up in 3 days. If the injury is still present, re-image the patient in 1 week. And if the injury is still present at that time, re-image the patient again in 1 month. It's not clear what we should be doing with these patients if the injury persists for 1 month or more. This proposal has not yet been prospectively studied. So there are many unanswered questions regarding minimal aortic injuries. For example, what's the optimal imaging follow-up algorithm? We don't really know. Should patients be followed even after injury resolution? It's rare for them to progress to more significant injuries, but we don't know how common that is. Should pseudoaneurysms be included in the definition of a minimal aortic injury? One could argue that pseudoaneurysms from a histopathological standpoint are different from intimal injuries. Should the presence of mediastinal hemorrhage alter management? Does the presence of mediastinal hemorrhage or periaortic hemorrhage in the setting of a minimal aortic injury indicate that the injury is actually more significant than what we think? What's the optimal treatment for evolving injuries? And what is the optimal conservative management for minimal aortic injuries? Now let's talk about some of the pitfalls in the diagnosis of aortic injuries, including failure to perform the correct exam, anatomic variants, atypical locations, atypical distribution along the aorta, and pediatric patients. Here's a patient transferred to our facility who received an abdominal CT for abdominal pain following a motor vehicle collision. We can see here near the top of the exam there's retrocrural hemorrhage extending inferiorly from the chest. We therefore recommended a follow-up chest CT, which revealed a major aortic injury with pseudoaneurysm formation and substantial mediastinal hemorrhage. So failure to perform a chest CT is a potential pitfall for missing aortic injuries. Here's a patient with a contour deformity of the proximal descending thoracic aorta at the level of the ligamentum arteriosum. There are smooth edges, there's no intimal flap, and there's no periaortic hemorrhage. This is an anatomic variant called an atypical ductus bump and is not an aortic injury. Here's a patient who received a chest CT following blunt chest trauma. There's a left-sided hemothorax, there's retrosternal hemorrhage, and there's mediastinal hemorrhage. There's also a tubular finger-like projection of contrast arising from the proximal descending thoracic aorta in the region of the ligamentum arteriosum. This patient went on to catheter angiography, and this is an anatomic variant called a ductus diverticulum. Here's a companion case of another patient with a ductus diverticulum who received imaging following a motor vehicle collision. Again, a finger-like tubular projection of contrast arising from the proximal descending thoracic aorta at the level of the ligamentum arteriosum. This is a congenital variant ductus diverticulum and not an aortic injury. Here's a case provided to me by Dr. Stu Mervis from University of Maryland. There's a small focal outpouching along the right wall of the proximal descending thoracic aorta. This looks like a small pseudoaneurysm. However, if you scroll down, this is actually a bronchial artery. So sometimes patients have very prominent bronchial artery origins which can simulate an injury. Here's an unusual case of a 13-year-old girl involved in a motor vehicle collision. There are abnormal mediastinal and aortic contours. And on chest CT, we see substantial mediastinal hemorrhage with a pseudoaneurysm of the proximal descending thoracic aorta. However, in the distal thoracic aorta, there's another pseudoaneurysm with periaortic hemorrhage. And on sagittal MPR, we can see that there are 2 pseudoaneurysms of the thoracic aorta. So this is unusual, one, because this is a pediatric patient. Major aortic injuries are not common in the pediatric population, and there are 2 aortic injuries. Here's an unusual case of a patient with an aortic root laceration. As you can see here on axial, sagittal, oblique, and 3D imaging, there's a large amount of mediastinal hemorrhage and hemopericardium. This is unusual because most of the time these patients die and don't get imaging. Here's a patient with abnormal bulbous contours of the right side of the mediastinum. On CT, the patient has a right-sided aortic arch which is transected. There's a pseudoaneurysm and large amount of mediastinal hemorrhage. So this is unusual because this is a right-sided aortic arch which is transected. Here's a patient with an abnormality of the abdominal aorta manifested by luminal irregularity, intraluminal flaps, and intraluminal thrombi. When you see this appearance, be sure to look at the sagittal and coronal reformatted images, which we can clearly see now. The patient has a transected abdominal aorta with pseudoaneurysm formation and intimal flaps within the aortic lumen. There are a number of treatment options for patients with aortic injuries, including open versus endovascular repair and immediate versus delayed. Typically, in the modern trauma center, most patients will receive immediate therapy with endovascular stent placement. This is a strong recommendation by the Eastern Society for the Surgery of Trauma. Imaging plays a big role in the planning for endovascular stent treatment of aortic injuries. We can see where the injury is with respect to the origin of the left subclavian artery, the distance from the left subclavian artery origin, and the caliber of the thoracic aorta just proximal and distal to the thoracic aorta to allow for proper stent selection. Here's a patient who received endovascular stent treatment of a major aortic injury of the proximal descending thoracic aorta. You can see the stent within the lumen of the aorta and its distance with respect to the origin of the left subclavian artery origin. In conclusion, aortic injuries are not common, but when they do occur are highly lethal injuries. CT is the de facto reference standard for the detection and exclusion of aortic injuries, with early diagnosis and definitive therapy improving overall survival. Immediate treatment of major aortic injuries with endovascular stent therapy is the most common treatment option. Advancing imaging techniques have resulted in the detection of smaller aortic injuries which in the past may have evaded detection. And minimal aortic injuries constitute approximately 1/3 of all aortic injuries. Here's a list of the references used in this presentation. Thank you for your attention.